Greetings from the Venous Association of India. And thank you, Professor Khanna, for the invitation. I'll be talking on deep venous thrombosis, DVT. DVT and pulmonary embolism actually constitute one entity called venous thromboembolism. The predisposing factors have been known for over a century. The Fitchaw's triad, stasis, hypercoagulable state, and endothelial injury. And when all three exist, it becomes a very high risk predisposing factor. The risk factors for thrombosis can be congenital, like deficiency of some factors, acquired, like prolonged surgery, immobilization, stroke, oral contraceptives, HRT, malignancy, to name a few. And there have been at least two new etiologies. One is long distance drive in an automatic car, and the second is COVID-19, which is a hypercoagulable state. We classify VTE into provoked or unprovoked. Provoked can be due to a transient factor like surgery or an irreversible factor like cancer. So this is DVT after hip replacement, DVT after knee replacement. Epidemiology, about 9 lakh cases a year, and in India, about 2.5. Mortality is high, 3.7 lakh deaths in the EU countries and 5 EU countries combined, and which is more than the deaths from CA breast, CA prostate, AIDS, and motorcycle accidents. In India, 15 to 20% of hospitalized patients develop DVT. 1 in 4 people die from causes related to blood clots. It is the number one preventable cause of death in hospitalized patients. So that's very sobering statistics. And even if you survive, it can have chronic consequences like recurrence, post-thrombotic syndrome, and chronic pulmonary hypertension. Now, we are aware of the patients who are at risk for thrombosis, and we can do prophylaxis for them. And we have a simple scoring system. Scores associated with clinical setting like minor surgery, major surgery, associated with the patient, what is his age, his sex, any malignancy, any hypercoagulable states. And according to the scoring system, we can give thromboprophylaxis wherever appropriate. Once DVT is established, it is manifest as pain, swelling, and redness. And again, we can predict by a scoring system called Wells prediction criteria, which is a clinical criteria as mentioned over here. And diagnosis is by a thorough examination and this criteria. Number 2 by D-dimer, and number 3 by imaging, basically venous duplex scanning. So D-dimer has a very high negative predictive value. Compression ultrasonography is 97% specific and sensitive for proximal thrombus, less so for distal calf thrombus. On ultrasonography, it's very simple for a trained person to give the diagnosis because there is lack of compressibility. You may actually see the clot and there is lack of flow. So next, in a very few cases, we do CT venograms. As you can see over here, that shows a huge clot in the iliofemoral vein up to the IVC, not going into the IVC. The gold standard used to be invasive venography. We do not do this now unless we are planning a therapeutic procedure. So here you can see the dye stops abruptly and there is a huge clot. If it is not treated, then the valves, you can see the valves over there will be destroyed and that will lead to chronic problems. So the management is to stop the thrombosis and minimize risk of pulmonary embolism. And recently we are able to actually resolve the clot also. So limb elevation, early ambulation, no bed rest at all. The treatment is basically to give an anticoagulant. We earlier used to give unfractionated heparin, now we give low molecular weight. Earlier we used to give vitamin K antagonist, now we give the direct oral antagonist. So low molecular weight heparin has replaced unfractionated heparin. 5 to 10 days of low molecular weight heparin followed by oral anticoagulants. These are the various low molecular weight heparins we have all been using, the doses, the trade names, the advantages, the problems of vitamin K antagonist, and the advantages of direct oral anticoagulants, which we are all very well aware of. There are basically two types of oral new anticoagulants. the factor 10A inhibitors like rivaroxaban, and the oral direct thrombin inhibitors like dabigatran. So for 5 days, we give low molecular weight heparin and then convert to any one of the direct oral anticoagulants. The various trials for all the newer or the direct oral anticoagulants, the RECOVER trial, the Einstein trial, the Amplified trial, and all of them have shown a non-inferiority of the direct oral anticoagulants over the vitamin K antagonists. So the treatment of choice is a direct oral anticoagulant in majority of patients. The dose, rivaroxaban 15 milligram BD for 21 days, followed by 20 milligram. And that's what we do. This is the recommendation. We start with, in rivaroxaban, we can straight away, without giving any heparin, we can start with rivaroxaban in the dose I told you. For the other oral anticoagulants, we start with a low molecular weight heparin for 5 days, and then followed by dabigatran, 150 milligram twice a day for 3 to 6 months. That's the dose. Now, that's what we do in the majority of patients. But if the patient has a large thrombus load, then what should we do? If we do just this treatment, we will still end up with recurrence and chronic venous hypertension. So there are newer lines of therapy, basically endovascular, where we lyse the clot by catheter-directed thrombolysis or a device. I'll be telling you about them. And there are various trials like the XIII trial, which have shown that for large thrombus load, it is much better to give catheter-directed thrombolysis. There is reduced incidence of post-thrombotic syndrome and a better iliofemoral patency. The ATTRACT trial did not confirm this, but there were a lot of problems with the ATTRACT trial. And so what are the recommendation now is that we do catheter-directed thrombolysis for young patients with massive iliofemoral acute DVT and a good functional status and low risk of bleeding. So that is the grade 2B indication in current times. And the procedure is very standardized. We cannulate the popliteal vein, put in a catheter, confirm the diagnosis, and then start giving thrombolysis. In between, we also aspirate, and we can remove a fair amount of clots in the majority of patients. There are some devices available like the trellis system, where we put a catheter balloon above and below the clot and then vibrate a catheter inside the clot and lyse it. And the aim is to have a normal vein with normal venous valves. Another device is the Angiojet. When you do not want to use thrombolysis at all, we can put in the device and aspirate. This device we have used quite frequently, the Indigo or the Penumbra device. Minimal or no requirement for thrombolytic agent. It's a mechanical suction device. And here you can see a huge amount of clot we had removed. It can also be used for removing clot from the pulmonary system, pulmonary embolism. So after we have lysed, we do a completion venogram, and if there is a stenosis, we dilate it. If required, we stent it also. IVC filters, we have been using less and less now, very specific indications where there is a recurrence or you cannot use anticoagulant, then only. And whenever we do use it, it is almost always a temporary filter. We remove it after the risk is over, like this patient who had a complicated cesarean section, developed massive DVT, and we put in the filter. And here you can see 3 months later, we have removed the filter, and that's a lovely Bonnie baby. Open surgery, very, very rare. I have done just one for a very terminal, almost terminal case, which we were able to salvage. And this was almost 30 years back. Compression stockings in all the patients. To conclude, DVT is not uncommon, can lead to pulmonary embolism, which is potentially fatal. Even otherwise can lead to chronic post-traumatic syndromes, venous hypertension, and chronic pulmonary hypertension. Treatment is by anticoagulants, low molecular weight heparin, followed by a direct oral anticoagulants, and in very selected patients, catheter-directed thrombolysis, mechanical devices, and IVC filters. Thank you very much. I'll be happy to take any questions.
With the permission of Chair, can we have the discussion in the end and have all the topics?
Sure. Yes, I think we will have the discussion at the end. Yes, Dr. Khanna. Please, can we just proceed with the next talk then?